We are very pleased to be here with all of you to share the first data that we can take BIOTRAIM study from the full data set. And first of all, for some people that may not know everybody from BioHub, okay, I just want to introduce you to Josh Lee, who is our medical director in USA, and he will be one of the presenters of the data. And also Andreas Pigares, who is our medical science director, who is also connected, and she will be also presenting some of the data. So the very first thing I want to say is that this is the first shot of data that we have obtained from BIOTRAIM. So because we are still analyzing the data. So we have more analysis to do during the summer, and the idea is to have a full report in autumn about everything, you know. And but nevertheless, we already have some relevant data coming from this full data set that we thought that it was important to share with you. And also because a part of this data has been accepted as oral presentations in the World Transplant Congress that you know that will be held by San Francisco in the first week of August. So going directly to the point, this is the agenda. And as you see, we are basically explaining results from BIOTRAIM study divided in two big groups. One is the pre-transplant data, and the other part is the cross-sectional data. Okay, and after that, we will explain a little bit what would be our communication plan for end of this year and next year, and then we will have some time, hopefully, for some questions, because it's quite a lot of information. And upfront, thank you for your patience to listen to all this that we know in advance that is a lot of things. Okay. So, as a brief introduction, I plan to be very quick. This slide for us is quite important because it summarizes that the field of medicine you're working, transplantation, is quite a complex one. So when you're speaking about clinical goals or objectives, the very first thing that we share with you is that there is no single thing that will explain everything. That's not possible. So you are dealing with clinical data, we are dealing with adherence to therapy, to healthcare system access, to many things. And we would like to focus at this moment on one side of this causality cake of what happens in transplantation, which is drugs. Is the immune system and the drugs that you use to control the immune system, which are immunosuppressant drugs. At this moment, you are working with the PK, I mean, with the pharmacokinetics of some of the drugs in order to make those adjustments. And what we want to offer, and it would be our, let's say, contribution to the field, is to add the PD on this cake, the pharmacodynamics. So to deliver a biomarker that could be good to understand what is the response of the immunosuppressant drugs in the specific patients, and that this piece of the cake could be useful in the clinical practice. In this slide, what I'm trying to say is that all this has a kind of timeline or dynamic point of view. It's not a static thing. In the patient journey, basically, you start with some clinical factors. Some of them are good, some of them are bad for the patient. And the very first thing that happens, as far as we know, is an immunological activation. So it's the immune system, the suspect of the murder, let's put it that way, okay, that is activated. And basically, you use immunosuppressant drugs in order to control this. And there you have two main things to consider. One is the pharmacokinetic, and the other one is the pharmacodynamics. That's the point where we want to make a contribution with Immunobiogram. After the immunological activation, then you move forward to the non-visible organ damage. And for that, you have the DSAs and some other markers, okay? related to kidney damage, and the final part of it is the histopathological damage, the visible damage in the BANFF. But this is quite of a dynamic thing, and immunobiogram would come at the very first beginning of the whole story in order to position the product correctly, okay? And I wanted to say that although BANFF, biopsies are considered the gold standard in this field because of the amount of factors that are influencing clinical outcomes, it should be understood in context. So you have to put a clinical context to understand the biopsy findings and all that. And I also wanted to say that biopsy is very advanced in transplantation, but immunology is the causality factor, the most important one toward what you see here, and it has not been so developed. So these are part of the story, the immunology that at the end of the day delivers pathological findings and clinical outcomes is the part that we want to focus at this with Immunobiogram and the thing that we offer with this product. So in a kind of integrative care model for renal transplant, we understand perfectly that you have to take into account many things. And these multiple things can be divided more or less in organ-related factors, like the histopathology and some renal damage biomarkers, like cell-free DNA and others that are currently in the field, also the assays. Some clinical factors, which are the typical ones that you are used to work with, and then you have the drug factors, the medication factors, and which are related to immunology, because this medication acts over the immune system. And then we have the PK and the PD, as I was mentioning before, and Immunobiogram comes here to help deliver information about the pharmacodynamic of the drugs. So the Immunobiogram as a test, I'm not going to explain all the technical details here, just a high-level reminder, okay? It's a functional test. It's a cellular functional test. So basically what we do is we obtain peripheral blood from the patient, we isolate the PDMCs, we stimulate them using CD3, CD28, sorry. So it's kind of a canonical activation of the T cells. And we culture the cells and we expose this activated culture to a panel of immunosuppressant drugs in order to see how much potency do have these drugs to calm down, to downscale the activation and proliferation of the activating culture. And this is after some mathematics that we have incorporated in a software. This comes out to a map that basically explains how much is the sensitivity of the patient cells to each of the drugs that are tested in the panel, which are basically 5 drugs, the 5 typical drugs that are used in transplantation. This technique, well, you can see here some examples. We perform triplicates for each of the drugs. Here you have examples of the triplicates you see that are quite concordant, okay, at this moment of evolution of the technology, and the coefficient of variation for each of the techniques, for each of the drugs. You see it here down, mycophenolic, corticoid, everolimus, sirolimus, tacrolimus. They are all quite nicely below 15% of variation, which is nice for a functional test, being not a molecular test. And this is the map that basically is the output of the technique. In this map, what you can see is a 0, which is the average or mean, okay, response of a representative population of transplantation to each of the drugs. You have here mycophenolic, tacrolimus, steroid, sirolimus, and everolimus. And basically, after all this, what we can do is we can position the patient response to the drugs in this map, and it shows if the patient has a higher sensitivity compared to the median of the population or a lower sensitivity to each of the drugs that are tested. Okay, sorry, yeah. So with this technique, we have performed quite of an effort being a biomedicine company, a European biomedicine company. We have performed 5 studies to date, okay, from 2017, covering all the feasibility and proof of concept of the technique to BIOTRAIM, which is our last study that we are going to share the data now. And with all this, we are confident that the technique is actually seeing something, and we really believe that this is something that is relevant and can be a contribution in transplantation. So moving forward. Okay. I give the scene to Teresa to continue. Okay, I can go put this.
Yes. This presentation is focused in trying to answer to these critical questions of interest. The first one is if the immunobiogram adds value to the clinical risk assessment in kidney pre-transplant patients. On the other hand, if the immunobiogram adds value during the 12 months of follow-up, during the first year of follow-up after kidney transplant. And finally, based on the cross-sectional cohort, if immunobiogram adds value in patients where an indication biopsy has been done due to a rejection suspicion in kidney transplant patients. I'm going to try to remember very briefly the study design. You all know that we included 3 cohorts. The first one is the longitudinal one. Patients were included in the study before the transplant. An immunobiogram was performed before the transplant, and 1 year of follow-up was done. And during this year, 4 additional immunobiograms were performed in all the patients at 3, 6, 9, and 12 months. In the case that some patient there was a suspicion of rejection and an indication biopsy was done, we also recorded the data at this time point, and an additional immunobiogram was performed. And in the cross-sectional cohort, patients with less than 5 years after renal transplantation were included when there was a suspicion of rejection and a biopsy per indication was performed. And just before the biopsy was done, an immunobiogram, a blood sample was extracted to perform the immunobiogram. And finally, we decided at the end of the study to include also a cross-sectional control cohort of patients with a stable clinical course that was defined as a lack of renal impairment without previous rejection episodes or indication biopsies, without de novo DSA, without change in the immunosuppressive drugs in the last 6 weeks, and without opportunistic infections in the last 6 months. This is just an overview of the centers who took part of the study. There were 15 university hospitals from France, Germany, Sweden, Spain, and Brazil. And here you have the final numbers, okay? 480 patients were recruited, and from them, 438 met the criteria, the inclusion and exclusion criteria of the study. And so finally, we have 128 in the longitudinal cohort, 270 in the cross-sectional cohort, and 40 patients in the control cross-sectional cohort. This is the consort diagram. And as I have said, we have 128 in the longitudinal cohort, 270 in the cross-sectional, and 40 in the control cross-sectional. Of course, we received some samples, some blood samples where immunobiogram could not be performed, okay? And finally, there were some immunobiograms that didn't meet the quality control that are defined in BioHope to accept the immunobiogram as a valid immunobiogram. And here are the final patients that we have analyzed and that we are going to present now. So first, I'm going to explain the multiple logistic regression model for rejection. What we're trying is to answer the first clinical questions, a question that I mentioned before. And what we have calculated are the rejection probabilities during 1 year follow-up in relation to the values of the immunobiogram pre-transplant adjusted by other clinical prognostic factors. We have used this statistical model where we compare two groups of patients. So the output can be rejections. There were 24 patients with a biopsy proven acute rejection. You will remember that we consider a rejection a BANFF category of 2, 3, or 4. I mean, we included borderline category as rejections during the whole year of follow-up. And the control group from the longitudinal cohort were patients without signs of rejection or inflammation in biopsies, without opportunistic infections, and without renal impairment along the whole year. We have get an overview of the immunobiogram with these two approximations. Approaches, yes, sorry. One is the sum of negative SID scores of the immunosuppressive drugs taken by the patient during the whole year of follow-up. What I mean is we make a sum of the immunosuppressive drugs that the patient have taken along the year. I mean, if, for example, the patient have changed from everolimus to mycophenolate, we count both drugs because we want to see really the whole effect of the whole treatments during the whole year. And we do a sum of the negative SID scores, okay? But also we have a study the mean of negative SID scores, that is the previous sum divided by the number of immunosuppressive that are included in this sum, okay? And of course, we have taken into account the traditional clinical prognostic factors that can be relevant for rejection incidence as covariates. So here is a picture of the baseline characteristics of both groups that were similar in most of the variables. Perhaps where we found more differences were in the recipient age, the donor age, the percentage of transplant patients. And this brings us to the next slide, where we try to explain which are the prognostic factors that we have included in our model that were recipient age, donor type, retransplant, the age mismatch, the PLA, and the DSA pre-transplant. And these are the results of this model for rejection. And we see that the immunobiogram sum of a negative SID score have an odds ratio below 1. It is a 0.4. First, I must say that the recipient age was not included in the model because a statistically significant collinearity was found between donor age and recipient age. So statistically, it was advisable to take it out from the model. And finally, we didn't include the pre-transplant DSA because there was only one positive patient with pre-transplant DSA, and it did not add any information to the model. Okay, as I have said, the immunobiogram results show an odds ratio less than 1 that indicate that the rejection is less likely to occur as the predictor we have used, the immunobiogram values, increases. Or said in another way, if the sum of a CT score negative moves to a more sensitivity value, what happens is that the probabilities of rejection decreases, okay? And that's why the odds ratio is of less than 0.4. And this can be translated in this figure where we saw the probabilities of rejection in the three levels of immunological risk that we have considered, taking into account the prognostic factors I mentioned before. And what we see is that when the immunobiogram sum of a z-score negative goes to a more sensitive value from -5 to 0, the probability rejection decreases gradually, and this happens at all the immunological risk levels that we have considered in this model. This is very nice to be seen in this figure, where you can see on the right part of the figure how the model of rejection is explained by the clinical prognostic factors, and the figure explained at each immunological risk level how much information the immunobiogram adds to explain the probability of rejections. Okay, and you can see that at all immunological risk levels, immunobiogram adds a very interesting information from the pharmacodynamic point of view. This was done also repeated with a mean CT scores negative, and we see again that immunobiogram pre-transplant adds value to the prediction of rejection to the clinical risk assessment at all immunological risk levels.
Thank you, Maria Teresa. I give the stage to Jos. Okay.
Thank you. And so to follow up on what Teresa was talking about, looking at risk scores and immunobiogram, this is also going to look at the longitudinal cohort and focusing in on the pre-transplant immunobiogram. So before I start, oh, I do it there.
Yeah, you have to put that. Yeah, that's it.
Got it. I just want to kind of say, we're starting with 107 patients that had pre-transplant immunobiogram. And I'll show you as I walk through this, there are certain things that we take out of this to look at smaller groups, and I'll explain the rationale for that in a minute. But as Teresa was talking about, in this, we're going to look at the mean ZS positive.
Yeah,
There we go, I found it. And the ZS negative scores. And I just wanted to follow up on that and what that means. So in this particular patient, what their ZS positive score would be the mean of any that are positive. So in this instance, they're only taking one medication that scored as a higher sensitivity to that particular medication, tacrolimus, and the score is 0.7. For the mean negative ZS score, you're going to take the mean of these two down below. So in looking at this group, we wanted to exclude the patients that had rejections or infections early in transplant, because the immunobiogram is meant to be utilized for maintenance immunosuppression. So when we look at some of the results that were occurring at early transplant, we thought that doesn't really tie into what I'm particularly trying to look at here. So let me.
I think you have to go down and to the. You know what I mean?
Yep, I'm working my way there.
I can do it for you.
Yeah, perhaps I'll let you. I'll just.
Yeah, I can do it for you.
So before we do that, I just wanted to kind of give you a snapshot of the fingerprint of what immunobiogram is showing us. And what you see here from left to right in no particular order is a group of patients that had pre-transplant immunobiogram. And then each of those bars is a building block of what their sensitivity is to MPP, TAC, MPA, everolimus, or sirolimus. And so if you look at position 1, you can see that patient is sensitive to MTP, TAC, and everolimus. And so this is just kind of to show you, yes, this is kind of to show you that there is variability in each of these patients. It's not like they all have kind of the same output from immunobiogram. And I wanted to show that as a preemptive to before we get into this. Go to the next. So my next thought, which was tied to what Teresa was showing us in looking at creating a risk score for the patients prior to looking at the immunobiogram. So what I did here was I used some, I'm from Portland, Oregon, so I used some of the tools that are in the US that are sometimes utilized, but also recognized as not being as predictive as physicians would like them to be, such as the EPTS, the estimated post-transplant survival, the KDPI, and some other factors such as BMI, smoking. And I kind of gave them all a weighted amount and put them into an algorithm and rated each of the patients. So patients are organized here from left to right, being lower risk to high risk. And then at the bottom, you can see the points there, which represent the type of rejection that they had in this cohort of pre-transplant patients. And you can see that there's not a grouping to the right. And so all of these factors that we know are risk factors for kidney survival, for patient survival, we didn't see them correlate. You would kind of hope that maybe they would be grouped to the right, but there was nothing to be seen there. So what I did next was taking those 107 patients with a pre-transplant immunobiogram. We then took out any patients. I wanted to use particular drugs that these patients were taking at 3 months. So if the data didn't have all of the information on their immunosuppression at 3 months, then those patients were taken out of this, because obviously we can't look at what impact of immunobiogram is happening if the information is there. So that took it down to 98 patients. And in that group, there were then 21 rejections and 32 infections. And then the next thought was to take out early rejection and early infection, because there's complications at early transplant that may not be tied directly to the maintenance immunosuppression that they're going to be on later. So we wanted to look at a time point with pre-transplant immunobiogram, looking at what medications they started at 3 months. So when excluding out the rejections, it got down to 91 patients for rejection. And for infection, there were 84 patients, and 14 rejections and 18 infections happened in this group. So what I want to show you next is the result of that. So as you look at this graph, the spikes on the top are the rejections classified by color by BANFF 2, 3, or 4. And the red line underneath is the mean of the ZS negative score. So like I showed you in the thing, you take the average of whatever scores they have and get a negative score there. And you can see that as these patients have a more negative score, the grouping of the rejections moves to the left. Kind of like in the earlier risk stratification, you saw them completely spread out. Here, you're getting a grouping that you don't often see in transplant. I think I've worked in a number of different diagnostics, and very rarely do you see something that has a nice fine line where there were no rejections to the right. So all of these patients to the right had 0 medications that they were taking that they were insensitive to. And you can see that there were 21 rejections that happened, and 23 patients that were spared rejection and had a negative Z-score. So now this part of it is the 98 patients. So this is not excluding the early transplant as well. So I think that also, it may not be relative to the maintenance immunosuppression, but it's pretty interesting to see this group together. But the next slide, what I want to show you is that if you take out the early rejections, it moves it down to 14 rejections that happened in the first year after at 3 months. And you can see that space to the right where these patients were spared of rejection as well, and 26 patients in this cohort. So yeah, so the other side of this coin is the positive Z-score. And in a similar vein, I took all of the patients that had a 3-month data for immunosuppression and had an immunobiogram pre-transplant. And you can see that the infections are throughout this. There are some to the right, they're throughout it, but the green line is the representative of those individual patients' positive Z-scores for medications that they are overly sensitive to. So after looking at this, there's a pretty strong suggestion that some of these medications or some of these infections have been caused by induction therapy, or perhaps some are with immunosuppression of the maintenance immunosuppression. But the red spikes there are all patients that had infections before 3 months. So the next slide takes those out of this equation, and you can see that now all of the infections fall within the ZS positive of the maintenance immunosuppression that these patients were taking. And again, just like in rejection, you can see the patients to the right with taking no medications that they are overly sensitive to did not have infections. So I think this tells an important story in transplant that we haven't seen, and it gives a significant tool for physicians to be able to categorize their patients for risk versus not risk. And there, you can imagine there's a lot of things that you could do in those groups to change the potential outcome of the patient.
Thank you very much, Josh. I give the stage to Andrea to explain, now move to the cross-sectional cohort.
Hi, so please next. Okay, so what we are going to describe now is the cross-sectional cohort, which is comprehends the patients who need to perform an indication biopsy against the patients who has no need of biopsy because they had a good course of a good and stable course, a good and stable clinical course. So next, please. Okay, here you can see the demographics of all those patients, and you can see that the comorbidities are a bit higher in the patient who had an indication biopsy. Also the donor age, like a little bit, or the renal function is a bit worse in those patients. We could think that these patients, 270 patients that were indication biopsy, had medical risks that we could relate to a rejection. So please, the next. If we go to the result of the indication biopsy that was reviewed by a central pathologist, we can see that these results are variable. So we find BANFF 2, 3, or 4 in around 30% of the cases that were performed a biopsy. And on the right side of the slide, you can see per country, there is, on the right column, there is a quite variability in between the results of the rejection. This is probably related not to the pathologist because it was a central pathologist, but to maybe to the protocols in every hospital could be slightly different, or maybe to the patients or something that we are not catching with this. So please, the next. What we can see with the immunobiogram is that we find there is a difference of the performance in the immunobiogram between the good clinical course patients, so the control, the patients that did not require a biopsy because had a good clinical course, and the patients who did have the requirement of a biopsy. And this matches the results that were already published in the Transversal trial. So please, the next. So these are really very preliminary results, but we can summarize that immunobiogram is consistent in evaluating the sensitivity to the immunosuppressant drugs in every cohort. And immunobiogram correlates with rejection as a tool to potentially avoid events. And it provides valuable information adding to the clinical risk assessment that could help decision making. And the immunobiogram in pre-transplant was able to classify an at-risk cohort and a group with considerably less risk than of rejection or infection. So please, the next. If we try to use it from a clinical perspective, we could say that we can use it in a pre-transplant situation or a follow-up of the patient, or maybe in an unstable situation with an indication biopsy. So what we can find out from this study is that in pre-transplant situation, if we have a negative Z-score or a positive Z-score, it could be a different result. So negative Z-score would be related to the rejection probability, and a positive Z-score describes opportunistic infections. So in this situation, in pre-transplant situation, we would recommend to revisit the treatment and try to avoid drugs that are far from zero in a negative value. During the follow-up, we would recommend to really add, we have to think that this is a very complex situation, and it depends on the medical evaluation and every other situation that put in context the patient. But we would recommend to get to zero. So if you have a negative Z-score that could be related to rejection, try to make the patient near to zero in the drugs, in the selection of the drugs. And in a situation related to indication biopsy, if we have immunobiogram Z-score over zero, so positive, this could describe an unstable course scenario. And if we have a negative, that would be related probably with rejection scenario. So we would recommend, or recommendation would be revisit the drugs and adjust the drugs, trying to get to zero, just to avoid infection. But this depends on the patients, because maybe the patient has a high risk of rejection, then one would decide to take the risk of infection and adjust the drugs in another way. But please, the next. So in how many situations would be possible for the report of the immunobiogram to give some information that could change the decision of the medical doctor that is facing this situation? We have been reviewing, these are very preliminary data. We have been reviewing the visit zero. This is pre-transplant situation. And we find that in the reports of the immunobiogram, around 79% of the reports, you could choose in between resistant or sensible drugs. And please, the next. We have analyzed other visits. So visit one, that happens the same. You can receive a report where you can choose a drug. And next, please. Same in the visit two, so 74. That would help or could help the decision making. And the next, please. Also in the last visit, that would be 83%. And the next, please. And this would be the situation more similar to the indication biopsy, because it's an additional visit, but there are only 7 patients. And well, in this situation with 7 patients, would be 86%. But of course, this is a very little number. So, and these are preliminary data, and we will need to analyze this further. So please, the next.
Thank you very much, Andrea. I give back the stage to Teresa to explain about the communication plan of this data that we have now, and also the data that we want to deliver. We want to analyze and we want to deliver during autumn, okay? Because we want to work also, I want to tell it here, in this PK/PD model, and try to combine the two things and do more things about the immunology in transplantation, because we have also some data coming from other sources like flow cytometry and others. And with all this, we want to have a kind of compelling full data set of data in autumn that we would like to deliver in a journal, okay, in a paper. So I give Teresa the stage to speak about it.
Well, this slide reflects the communications we have done for this year. So we have sent and have been accepted to abstracts to the WTC that will take place in August in San Francisco. And both have been accepted as oral communication, and they are reflecting. I sent these abstracts to all the IPs of the study, and they reflect the results that we have saw here today, me and Josh. One was a late-breaking abstract, and like 5 days ago, I think they communicate us that it has been accepted for oral communication. We have sent also one abstract to the Congress of the Spanish Nephrology Society. We are pending the answer. And of course, as Isabel had said, we hope to have the first draft for a paper publication probably in December 2025. Okay. And of course, there are so many things that can be analyzed in this study because we have also pick up data that allow us to create like pharmacoeconomic models, and we have data from flow cytometry. So we think really that we can probably we will be able to develop several papers, and we are going to present also different results to this Congress, to the cutting edge of transplantation, to the SET in La Coruña next year, to the ATC, to the PTS, and to the ESOT that takes place each 2 years. So the next one is going to have place in 2027.
Okay, so thank you very much. This is the presentation. I'm going to take this out now. Okay. Right.
It's good because we have time.
Yeah. So I think that we have time for questions or suggestions about this first data set coming from BIOTRAIM, and we will be happy to answer anything or take care of any suggestion about all this. So the microphones are open for anybody that would like to say something.
I think
Okay.
Julio.
Yes, thank you very much to all the team for the nice presentation and this great amount of data, which is a little bit difficult to assimilate or to digest at this post-pandrial time. So I would like to emphasize the importance of the zeta scores and the prediction of acute rejection that we have during these first 3 months. I think this is a very important start point for having this tool in our armchair to develop a good prediction model. This is very important, and of course, all the rest, the sensitivity to the drugs, etc., etc. So I only have to underline my congratulations for this great effort. I think that for BioHope, it has been very, very important and difficult to get all this data together, to have all this process of data analysis. And this is perhaps only the start point. So we will have a lot of good results coming. Thank you very much.
Thank you very much, Julio. On behalf of all the team and that you, all the investigators, have been part of it. And I would like to thank you, everybody. And if you don't mind, I would like to add that we as Europeans, and now in this world, okay, that we have now, we are always struggling with the idea of being important in the world to deliver innovation. And this is precisely what we are doing. And we really thank all you, all the physicians that are helping us we together, okay, to deliver a nice innovation to this field.
Marta, please.
Yeah, I was going to speak in the same line as Julio. No, we have a lot of data now, and your new analysis saw the promising tool that immunobiogram can be for the patient. So we are closer to the patient. So not only the association of sensitivity or resistance with a certain situation, but some kind of prediction. So that's going to be very helpful. And I know that we have to wait for further analysis and maybe some interventional approach or something like that. But this makes the test more appealing for the clinical setting. So congrats.
Thank you, Marta.
Thank you.
José María Portales. José María, you're on mute.
Sorry, I'm an old man, sorry. Okay, in the same line, I will thank you for all this information. I believe that we should plan analysis in the line of the clinical point of view. In this sense, the most important slide for me is the slide of the intended use scenarios of immunobiogram. I believe that is very important to put in context all this information and to convince a clinician about the practical utility of this test. I believe that when you have all the data from the follow-up study, you can get more information about this analysis for the follow-up assessment. And it's important to take the clinician point of view to put in context these new tools. My last comment is that I don't know if this is a strategy, but I have shown that the communication plan during the next year focus only in the transplant meeting. I believe that it should be of interest that any new data will communicate in the nephrologist Congress, at least in Spain, because you have a lot of people attending there. And I believe that it's important to give more information about BioHope. Once again, congrats for the results, and we hope for new results.
Thank you. Okay, I don't know if there is any other comment or not.
Yes, I have one. I would like to say also that after all these years of development and fundraising from BioHope and all these very, very difficult getting funds process, I think that now the centers should start using this in their hands. It is always difficult to have a new product that is not very, very strongly regulated until now, but I think we can use it in the hospitals. And when some board of directors would like to use it, perhaps the clinicians are not that convinced, and vice versa. So there are clinicians that are dying to use it, but then the directors say, no, we don't have a budget. But anyway, I think that now we have the opportunity to take these results, to learn of them, and to apply in the real world, in the real life, what these results say to our own patients in our own units. And I think this would be a good way to go, not waiting again for a couple of more years of a new study that, of course, we need interventional studies, we need to proceed, to need to pursue strong data to support the use of it. But the real world data will be essential for development of this tool.
Julio, I want to thank you very much for what you have said, because you know that we in BioHub, we are basically a team of an R&D team, basically, okay? As you are. I mean, we are basically innovators. We are researchers. So I would encourage you all to help us also understand the best usage of this new tool. I mean, this is something that we should discover together.
Sure.
So
That's a point. Yeah, I fully agree.
yeah. So I really appreciate what you have said, because if you let me say this way, it shouldn't be only on our arms all the responsibility of delivering the whole full package of data for everything. I think that this is something we should work together and to come together to the best usage of this new novel tool, of this new technological platform, okay? And I would encourage you to do this with us. I mean, and this way, it would be best, because you know more than us about your patients and about your clinical setting. So it's completely logical that we seek your advice and your help in order to understand the best usage of this technology. So thank you very much. If there is not more other questions or comments, okay, I would like
Ana.
to. Yes.
Ana del Prado.
Yes, I have only one comment. I would like also to congratulate all the participating sites for all the good job, mostly considering our job, that is just to follow all the investigator to complete the data on the CRF. So we would like also to congratulate your study team coordinator for the great job that you have been performing during these years. It's just that apportation from my side. Okay.
Absolutely agree. Good point that you did it, because in fact, I should have done it. So thank you very much to you all investigators for participating in this study and giving all your work and all your thoughts. And also I want to thank Dr. Julio Pascual and Dr. Dr. Marta Crespo for their insights in the design and all the follow-up and all the support that they have been given to deliver this data. Okay, and we will also disturb you in the future to do more things together. And said that, I think that if there is no more other comments, we can close the meeting here. Thank you very much to all of you. Those that are attending the WTC, we will see each other there. And if not, in the rest of the congresses that we mentioned. And I tell you that we will have another investigator meeting when we have more analyzed this data. We will have new information, and probably we will join you all together in autumn to see more data. Okay? And thank you very much to you all. Really appreciate it.
Thank you.
Bye-bye. Thank you.
Thank you so much.
Bye.
Thank you.
Good evening.
Bye-bye.
Bye-bye.
Bye, everyone.